it gives me great pleasure to bring Donnie Akers to our very first Symposium for No One. Thank you, Donnie. The show is yours.
Well, I appreciate it. Thank you, Linda, very much. I have a special connection with HANY and feel a certain kinship with my New York peeps. For those of you who don't know, I'm coming from right today, Natchez, Mississippi, where I evacuated from Hurricane Delta, which just crossed into my home state. I basically live 100 miles east of where the eye just crossed, and we're getting the highest reported winds outside of that localized area, I'm told. And my power went off at 4:30 this afternoon, but I've made a reservation to come up north to Mississippi, Natchez, if you've ever been. If you've not, put it on your bucket list. Phenomenal place. So that I could do this presentation, and also because it is my birthday, it was a little birthday gift as well. Nonetheless, Linda, I don't know if this is sponsored by anyone, but let me just make this disclaimer, other than HANY. I don't know if it's an HFA or whatever presentation. Any opinions, any snide remarks, any criticism, any foul language perhaps that sometimes slips into my presentations. I just want you to know that all of these are mine. They're not the opinions of HANY or anyone else. So hold me accountable and hold it against me if I say something. I'm just trying to get you to understand the reality of a lot. So with that being said, let's go ahead and get started. Today, especially with COVID, we're all experiencing a whole new way of being taken care of with regard to our health care. We have telemed, we have urgent care centers, which basically are the newest things that bypass going to doctor's offices. We still have those traditional situations, but we also, and especially in this community, have emergency rooms that we seem to sometimes often have to go to when we are at a last resort situation. Now, let me just go ahead and recognize that the most expert people in bleeding disorders, in hemophilia of any type, factor one, which I just learned about actually after 20 years in the community. I've never ever dealt with it before, but I called my good friend Dr. Chris Walsh, and he basically gave me some information, and I did the Google and learned a little bit about it. But basically, if I'm correct, the fact situations and the experiences of patients with factor one are quite similar to the other factor deficiencies. So I'm going to use that premise as my stepping off point and assume that there are so many commonalities. So with all of these new modalities of taking care of our health care, there's one big overriding thing, and I think you probably all agree, that healthcare is not only about the Hippocratic Oath and taking care of people and healing the sick, but it's also a big business. And volume of patients seen means volume of insurance payments and third-party payments and profit, et cetera. So we got to basically, as patients, navigate that system and make sure that we are in the crosshairs of those who are supposed to be taking care of us with some importance. So probably all of you have experienced, your bleeding disorder and going to an emergency room or seeking some type of medical care, and you probably had difficulty and some potential harm. I've heard horror stories for 20 years, and although I think things may be getting a little bit better because we have more tools, which we'll talk about, it's still a problem because we're rare, and you, with factor one deficiency, are rarer than rare, and you know more about your condition than the doctor, the nurses, the triage people. They can't spell it. They don't know what to do. They attempt to do things by standard procedure, which don't apply to us in our community and in these conditions. So that often presents a problem. So with that problem that you're faced with, you have to kind of do some self-evaluation and start to really think. This is about you. This is about your body. So first question you need to ask yourself is, are you passive with regard to your healthcare, or are you active, and do you share in your healthcare decision making? Do you collaborate with your doctors and your other healthcare providers, or do you just sit there, take what they give you, listen to what they say and do it without asking any questions, and maybe just being that patient bump on a log? You know, it's your choice. I think that you probably are not going to get the best care if you're that person, but if you're sharing collaborative, that's the goal you want to achieve. So, you know, I want to just, and I'm going to stress this many times, but you have rights as a patient. You have the right to make informed decisions about your care. You have the right to be informed about your health status. And you have the right to be involved in care planning and treatment. And you can request or even refuse treatment. Unrelated to bleeding disorders, but during this COVID, a few weeks ago when we were experiencing the last hurricane to hit Louisiana, Hurricane Laura, which basically had virtually the same track as Hurricane Delta and decimated Lake Charles, Louisiana, and the western part of my state, I started to have a dental issue. Thought I was getting a crown replaced, and ultimately it ended up with me being sent to an endodontist for a root canal. How fun. But we had to delay that because of Hurricane Laura. So I'm calling my dentist and begging for pain pills and, you know, anything short of shooting me at the time, because it was really some of the most excruciating pain I've ever had. I get to the endodontist, and ultimately he finds the culprit, which was an inflamed nerve, but he had to stop the root canal because he determined that I have a fracture in the tooth that he was working on, and did not know whether we should continue and whether or not my crown should be replaced. That being said, he got me out of pain, and I didn't care what else he said at that point in time. That's all I heard. So my dentist's office was not informed by the endodontist office of what he found. And I got a call from my regular dentist to schedule the crown replacement. And I informed the clerical person who called me about the appointment that, you know, what had transpired. And so back and forth, I get a call from her, who also happens to be his billing clerk, and is talking to me about, well, the doctor wants you to go, we're going to make an appointment for this oral surgeon to consider extracting the tooth, and then we're going to do this and do that, because you already have paid, you know, all of this money for this. And finally, I just said, stop, hold it. And this is the dentist that I've been seeing for 25 years, and I consider him a friend. And his staffer I have known, and she's been great. I told her this: I like you, don't take any offense to this, but I want to speak to the dentist about my treatment plan. You are not the person that I want to be talking about who and when I make appointments for these procedures and this and that. And she said, I understand. I said, well, I'm glad you do. And I will be making an appointment, and I want to sit down, not in a dentist chair. I want to sit down at a table, and I want to have a discussion about what we're going to do, how we're going to do it, and, you know, where we move forward. So that's an example that's unrelated to hemophilia and bleeding disorders, but basically it's the essence of doing what you should do. Put the brakes, insist on your rights, and, you know, get the information. All of this basically is in the medical world and in the legal world, actually, it's called informed consent. Hospitals, doctors, dentists, whomever, have to use a process that assures that the patient's given the information and disclosures so that you can make an informed decision to either consent to a procedure or whatever they're proposing or not. So you always remember, have a say, and you have the right to refuse. And that's kind of where I'm at right now with my dental thing. Until we sit down and speak, it's not going to be what the billing clerk had on her list of instructions. So informed consent is more than signing a written consent form. And you've all been in various doctor's offices and places, and they stick a bunch of papers out on a clipboard and tell you to sign here, initial here, check this, you know, turn it over, sign there. Who reads this stuff? Well, you know what? Your signature is not an ornament like you hang on a Christmas tree. And when they have that, that means something, unless you have to try to controvert it or prove otherwise. So you have to have that communication between the patient and the physician. in my case, between me and my dentist. And I want to, and I have the right to have an opportunity to ask him questions and to have a better understanding so that I can either decide to proceed with what the billing clerk, indicated his plan was, or to refuse what he's suggesting. But this is going to be after we have the conversation. And it's the physician, or in my case here, the dentist, not his billing clerk, not a representative, not a nurse, not the ward clerk. It's the person who's going to be doing the treatment. They should disclose and discuss. This is not something that you should assign, should be assigned to anyone else. So you can insist on that. It is your right and it's legally recognized. If they're doing the other way, then they're cutting corners and they're going to be on some slippery slope. So you want to know the diagnosis if it's known, the purpose of the treatment, and you're also entitled to know what the risks and the benefits of the treatment are. And in fact, did a little bit of research, and New York Public Health Law 2805D, interestingly, talks about a lack of informed consent, and it defines informed consent. And it's all of those things I just spoke about. The physician being the one to talk to you, you're having the right to ask questions, get information, be told the whole, much more detail that you need to know before you can make a decision to proceed or not. And the patient's required to be provided with that information. And I like this. I've never seen this before, but I took it from the statute. It says the patient has the right to a knowledgeable evaluation. They don't just come and evaluate you and tell you something. That conversation makes you and the doctor have a knowledgeable evaluation. There's another interesting piece of legislation from New York that I found that I want to point out to you in case you don't know about it. But there's a New York Patient Bill of Rights. Your statutes, the law requires, if you're in a hospital in New York State, you have the right to basically all of these things, to be informed of the name, and if it's in a hospital, the position of the doctor. Is he an attending? Is he an intern? Whatever. And also who are the hospital staff that you're going to be dealing with. You have the right to refuse their treatment, their exam, or their observation. You always have the right to refuse, unless it's an absolute dire emergency situation and you're not really capable of making an informed consent decision. Then that's a whole different ballgame. But in ordinary circumstances, you have the right to refuse. You have the right to receive a complete information about the diagnosis, treatment, and prognosis. And, any and all information that you need to give informed consent is what this Patient Bill of Rights requires. Again, refusing treatment and be told, what is the effect? If you refuse treatment, we're going to tell you this is what's going to more than likely happen. That's okay. You make the decisions about your body. If you're competent and have the mental ability to make that decision, it may not be what the doctor or his people are telling you what they would do, but ultimately it's up to you. And sometimes, and I throw this in there because it is part of the Bill of Rights, if it's research, and we have specific rules about informed consent in research projects, you have the right, again, to informed consent in those situations. So that out the way, understand that it's your right, know what you're doing, stop the process, refuse if you want to, if you feel that that's the best, in your own best interest. It's your body. There's been for years a question in the hemophilia community as to whether or not there's a standard of care. How do you treat hemophilia? And then a lot of people would go to the hospital and they want to, know, and have asked, can I self-infuse when I'm in the hospital waiting in triage for 2 or 3 hours because they tell you you don't look like you're bleeding to death? And we have patients who are obviously visibly in worse condition than you, of course, because they don't understand, they don't know the condition, and they don't know that you're there as a last resort because you know and have done everything that you could before you go to the hospital. The other question is always, can I bring my own factor to the hospital? And those questions have always been answered by most hospital ERs especially. can't self-infuse. Our hospital rules and regulations don't allow it. And no, you cannot bring your own medication to the hospital. We don't know what's in there, and we're concerned about, what you're going to try to ingest, infuse, or whatever. And for liability purposes, we don't allow that for any type of condition or any kind of patient. Well, that was the question and the conflict for many, many years in the community. The standard of care, that term, and if you use it when you go into an ER or into a medical situation where you're trying to, number one, get informed consent processes started, but if you drop the term as an educated person about your condition, use the term the standard of care. Tell them, well, the standard of care for my condition requires this, or the standard of care in this situation requires that we do that. That's going to get their attention, because most patients are not walking into a medical situation or an ER and dropping the term standard of care. So what is the standard of care? The definition in medicine is a diagnostic or treatment process that a clinician, a physician, a dentist, whatever, should follow for a certain type of patient, illness, or clinical circumstances. So someone who is going to be treating someone for a bleeding disorder, there's going to be a certain protocol that they would follow. And I'm throwing this in here for the first time in this presentation because we've been using the term, I've noticed in many, many of my circumstances in my practice and other areas. Best practices seems to be the buzzword today. And best practices is basically, if you can use the best practices, that's going to be your standard of care. You determine what the best practices are, and that's what's going to happen. Let's say you go to the ER and they don't let you infuse or bring your factor in, and they do things, and ultimately you have a bleed, and you ultimately have a lot of pain and suffering, and maybe even some permanent damages. Then you might be calling someone like me, a lawyer, and say, I have all of this, and they breached the standard of care, and I have this damage, and I've lost work and pain and suffering, and I now have a knee or whatever that needs to be replaced, and I'm going to just be ruined for such a long time. Well, in law, the standard of care, again, is what would an average prudent medical provider practice? In other words, what would those best practices be for someone similarly qualified about your condition? And typically in medical circumstances, they want to look at, and I would be trying to find out, what is the standard of care? What is the best practice out there for doctors who practice in a certain community? What would they all do? Well, in the community of bleeding disorders, you don't have a lot of hematologists and HTCs in an area doing everything. So you have a larger, more national expertise of the prudent medical providers who practice in hematology. So if I would look for something, I would find something to see if I could prove on your behalf that the standard of care has been breached, that you have been harmed. And if we can find those, then we can show that there's some legal liability, also known as malpractice. And they are scared of that. And everybody should be, because it means that somebody's made some mistakes and there's been some harm to someone. So the legal definition of standard of care, if it's breached because of the medical standard of care not being followed, ends up in a malpractice action. So for many years, we did not know or didn't have a standard of care for ER doctors and all that. And I think it's 12 years or so ago, I was a representative for Hemophilia Federation of America at a meeting with the American College of Emergency Physicians head doctor. And we all met in Dallas, and basically we're trying as advocates to get them to, if nothing else, to change the standards of care for ER emergency care of people with bleeding disorders. We were trying to get them to understand that we were different and that there should be differences in how we're treated because of all of the horror stories, and you couldn't infuse, and people ultimately getting the wrong factor, stuff that they weren't prescribed, or in many cases, many people, especially a family I remember meeting, whose infant born spontaneous mutation, no family history, traveling, and their child is given a plasma-derived factor. Well, of course, that brought up all of the issues of the tainted blood supply of the 80s and HIV and all these co-infections. So that was very, very distressing to them. Fortunately, in that situation, nothing negative happened, but nonetheless, we had that issue. And so the head of the American College of Emergency Physicians listened to us, and he actually agreed that there was a need to have a special standard of care for ER treatment of people with bleeding disorders. And we left there feeling very positive about the change, but ultimately it didn't happen because the bureaucratic, liability concerned, business side, I believe, of medicine as it's practiced in hospitals, they weren't going to change the standards of medication, administering it, bringing it in to hospitals for such a small population. They just weren't going to do it. Because if they had done it, then we could have certainly relied on that. And I'll never forget, one of my best friends who I grew up with was a professor of emergency medicine at UC San Francisco General, where they have a phenomenal HTC. But he didn't have much interaction with him. And we had a pretty heated argument about this. And he finally told me, and I finally got it. He said, Donnie, I have been practicing in that time probably 25 years in the emergency room. He says, I maybe have seen a handful of people with bleeding disorders. He says, what we do in emergency rooms is we stabilize patients and we send them off to the appropriate specialty to take care of them. We don't make follow-up appointments. We don't get or send Christmas cards to these patients or get whatever. He says, this is not a standard medical practice. We are not going to change rules for a specific small group of people. I got it. So ultimately I just said, well, we got to live with this. Let's educate our patients so that they go in there as advocates and they have to basically fight their way through, but with education. So I was so excited in 2019, or actually it was 2017, when MASAC, the Medical and Scientific Advisory Council of the National Hemophilia Foundation, they came out with guidelines for emergency department management of persons with hemophilia and bleeding disorders. Now, that document was 257 from 2017, and they replaced it, I'm sorry, it was 252. They replaced it in 2019 with 257. And in essence, basically, 257 is just a PDF version with a few tweaks of the 2017 revision. And so they call it guidelines for emergency department management of bleeding disorders. They have to use the term guidelines for legal and other reasons, but I call it a standard of care. And if you come into my office or any office of a lawyer who practices medical malpractice, by the way, I don't practice in that field, when they're going to look for the standard of care and they land on this document, it's pretty concise, it's pretty informative, and I believe that an attorney can successfully argue this is the standard of care, and then if breached, show how it was breached and how the person was damaged. So here is a screenshot of that document, and you should all go to the National Hemophilia Foundation website and pull up MASAC number 257 and download it into your phone. You should make sure that your regular treater, hospital, whatever, has it in your file, and if not, you always carry it with you, because this, when you start talking standard of care and you get their attention, might piss them off. But you keep saying, no, you can't do this. No, you can't start an IV drip on me. No, you can't do that. No, I need to be triaged immediately. I have a bleeding disorder. I'm here because it's worse than what I can normally handle. It can be fatal. It can have morbidities and things like that. Just keep using that term. So what does the MASAC document address? It addresses your triage. It talks about assessing the patient. It talks about whether or not they should be using diagnostic studies like x-rays and CAT scans and this and that. It talks about the factor that you may need to infuse and general treatment of a person with a bleeding disorder. So these are the areas that it covers. And in this kind of pointing all these things out to you, I'm not giving any medical information, trust me. I had a hard time spelling the word instead of factor one, whatever it is. It was too complex for my simple mind. I had to go back and forth and check it 3 times. So no medical advice from me. This is what MASAC kind of says, and these are just highlights. They talk about triage and they say, and that's standard of care when you're in that emergency room and they're giving you the run around and pushing you back, you need to let them see that you should be triaged urgently because delaying in factor can significantly affect you. Can be long-term damage. It also tells them that you should they should consult with your hematologist or your HTC. So you should have that information available for those docs to call your doctor, and your doctor is going to want to or be available, or someone's going to be available to tell them how this works. They also should not delay giving clotting factor while they're waiting for the doctors to communicate, is what MASAC says. When they assess you, they basically should listen to you give your clinical history. If you're suspecting this is a bleeding episode based upon your diagnosis and what you have lived with all of your life, then this tells them, listen to your patient. They know what they're talking about. It tells them that physical exam might be normal in an early phase of a bleed. It also tells them about spontaneous bleeding being common, and that no matter what, they should let you administer clotting factor. If they haven't, fine. There's some rules that we'll talk about that they suggest we follow as well. But clotting factor replacement is immediately needed. If, again, in the assessment protocol, they should base whatever you're there for. The first suspicion should be it's bleeding related. If you're there, you've got hemophilia, bleeding disorder, listen to the patient again. Administer factor. And it also tells them that patients are often instructed to carry with them their dosing guidelines from their hematologist. Bring your treatment plan with you. Get your plan written up, nice stationery from the HTC or hematologist or whatever. Have that information. These people like to communicate and talk to and respect each other more than they necessarily will respect you. This goes a long way. Diagnostic studies. If you're going to have x-rays, especially if you have a head trauma or a hemorrhage, they basically think that you should be x-rayed after you've infused. And they don't really recommend x-rays for just joint bleeds. They talk about the level that you should before procedure or surgery. And they also state that, hey, stop running up all kinds of bills by doing all these routine labs. And no, you don't have to do blood work to determine whether or not this person has hemophilia and what their levels are. They don't need to do that in most cases because you've got it. Your levels are pretty consistent and constant throughout your life. They're just wasting time and money. And, you don't want to have to deal with that later on either. So in all of the MASAC guidelines, the common theme that we see in what they say as this standard of care is administer factor within 1 hour of arrival at the emergency room. It's hard to do that if they won't let you bring your own, if they won't let you infuse in the waiting room, and especially if they don't see you and triage you and get you in urgently, immediately. Then if that's the case and you brought all this to their attention and they harm you, they got a problem. They got a little malpractice issue that they may have to contend with. So generally, this is a summation. Bring your factor to the ER. Have your factor mixed in the ER. If they happen to have your factor, which is not necessarily likely in most cases, it's too expensive for them to just stock it. But if they do happen to have yours in the pharmacy, don't let them mix it there and send it down. That's how mistakes get made. That's how the mom and dad with the brand new baby got plasma derived instead of a common factor. You also want the box, the lots that you can keep your logs, as is so important. So make sure that they mix it in the ER. Let them know that they have to administer it with an IV push, not hang in a bag and doing a slow drip. That's what they want to do. That's what they're used to doing. You may have to have a little fight, but show them the standard of care. Show them the ER guidelines. It's in there. Always, 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 it's about speaking up and advocating for yourself. Ask questions. You're not there to be nice or to get the congeniality award. You're there to take care of yourself. And if you're in this situation, it's serious. You need treatment. And if they refuse, if they won't cooperate, if they won't listen, as one physician who no longer is with us, but who was the father of a son with hemophilia, we were at something once, and I drove someone to an ER for one of our conferences who was having a bleed. And the emergency room was so overcrowded, and the response was so atrocious, even though we had in advance set up connections for our conference. He told me to get the patient back to the hotel because, my God, they're going to kill him. And so if a doctor can say that, then you can say it too. It's your body. So remember, unless there's a genuine emergency, informed consent is required. If it's an emergency and you don't have the capacity, or it's a life-saving thing and they know what they're doing, good. Because if they don't do it, they're going to subject themselves to legal liability. And in fact, that New York statute about informed consent is actually a medical malpractice statute. And so the lack of proper informed consent with a mistake and damages to the patient is what results in that. So basically, be empowered. It's your body, you have the right. Be informed, it's your body, you have the right. And the best advocate is you. Or if you're mom and dad with your children, the best advocate is mom and dad. Don't get in their way. I certainly wouldn't suggest it. So that being said, the information I'm giving you is informational. It's not legal or medical advice. Seek experienced legal counsel if you need to, or medical providers, to specifically answer any questions that you have. And if you ever want to contact me, I've been an accidental volunteer in the community. I have no physiological connection to hemophilia or bleeding disorders, but I am an emotional person with a bleeding disorder after all these years. And it's my privilege to get calls and emails from people from all over the country. And I'm always happy to try to help out in many, many areas that I speak on. So this is, my contact information. Don't hesitate. Say you heard me present, or I've had it where my friend told me to call you because she or he heard you present on this topic at such and such a place in the country. Very happy to do it.